Hello guys, this is Dr. SNK back with the next video, that is the microbiology part 2. Here I will be dealing with the other systems such as respiratory system, central nervous system, genitourinary system and all the miscellaneous topics which are related to it. Okay, such as the bioterrorism agents, oncogenic viruses, congenital infections are some of the important things, and others also, okay, like STDs and sexually transmitted infections. All those will be dealt here. Okay, coming to the topic ahead, that is starting with the respiratory system. Diphtheria. Okay, diphtheria. So basically diphtheria is caused by a bacteria called as Corynebacterium diphtheria. Okay, I have not written here, so you have to write it. The causative agent is Corynebacterium diphtheria. Corynebacterium diphtheria is the causative agent. Coming to the initial talks of it, that it is a gram-positive bacilli, non-capsulated, non-sporing, non-motile. Okay, these are the initial things you're going to know. Then the virulence factor is basically the diphtheria toxin. So diphtheria toxin, it is very similar to the exotoxin A of the Pseudomonas. Okay, basically what it does is, there are two fragments here again, A and B. A is helping in elongation of the factors such as ADP ribosylation, same like cholera toxin. The A fragment is going to do ADP ribosylation, but here it is elongation of factor. There it was different. Okay, there ADP ribosylation of CAMP molecules. Okay, adenylate cyclase was stimulated. Here it is elongation factor 2. So once this at ADP ribosylation occurs, this particular elongation factor is inhibited. Okay, it doesn't like the ribosylation. So what happens is, this factor is inhibited, leading to the inhibition of protein synthesis and cell death. Okay, whereas B, it binds to the receptors of host and helps in the entry of the fragment A. Coming to the types of diphtheria, respiratory diphtheria, cutaneous diphtheria are the most common encountered types. Coming to the respiratory diphtheria, it is the most common variety of diphtheria, that is also called as facial diphtheria. So here the sites are basically nose and larynx. You're going to see pseudo membrane which doesn't peel off easily, and it bleeds on peeling. The swelling is in such a way that the swelling in the neck will look like a bull. Okay, so it is called as bull neck appearance. Cutaneous diphtheria, most commonly you're going to see the ulcerative lesions. Okay, ulcerative lesions with necrosis. Complications such as cranial nerve palsies, peripheral neuropathy, ciliary paralysis and myocarditis. The lab diagnosis of this particular disease is again here. So it's based on the clinical signs. Okay, it is based on the clinical signs. The specimen is again throat swab. Direct microscopy will show the club shaped gram-positive bacilli. You're going to see Chinese letter pattern, that is VRL shaped. And the Albertstein is very specific for it. It is composed of malachite green and toluidine blue, as I told in general microbiology. So you're going to see what here, basically you're going to see the metachromatic granules. The culture, there are two things you're going to see. One is low-flux serum slope and potassium tellurate agar. Low-flux serum slope is used for early detection, whereas PTA, it is used for late detection. In this, if that's which is more specific, you're going to say it is PTA, it is more specific. And you're going to see the black colonies in the yellow background. Toxic detection. Okay, toxin detection is basically an LX gel precipitation test, and the others are PCR, ELISA and immunochromatography as usual. Coming to the LX gel precipitation test, it is a immunodiffusion test. You are going to check the immunodeficiency here. Okay, immunodiffusion is checked here. So basically what you are going to do is, first you are going to make a antitoxin strip. You are going to apply the antitoxin strip in the perpendicular manner or in the horizontal manner. So after applying it, you are going to add what? You are going to add the tests. Okay, what are the tests? The strains. Okay, the strains are added. Both, they will be containing both toxigenic and non-toxigenic, until or unless there is some colony formation or the precipitin formation that is not known. So after adding, how are they added? Basically they are added in the perpendicular fashion. They are going to be added in a perpendicular fashion. They are added in a perpendicular fashion to this particular strip. Antitoxin strip ಗೆ perpendicular ಆಗಿ ಹಾಕ್ತಾರೆ. Okay, after that you are going to incubate for 24 hours at 37 degree Celsius to see the precipitin lines. So once these precipitin lines are formed, these are this X mark, whatever marked here is the precipitin line. So once these precipitin marks are formed, that indicates the strain produced is toxin. The strain produces toxin. The strain is producing the toxin and it is reacting with the antitoxin strip and it is bringing about the precipitation reaction. So that is what you are going to see here. See, these are the precipitins formed and it is a toxigenic strain. Here there is no precipitin form, so it is non-toxic. Next, coming to the DPT vaccine related to it. So basically, what are the things you must be knowing related to it? Okay, diphtheria pertussis toxin, which is a pentavalent vaccine if you are combining with Haemophilus influenza. Okay, it is started at 6 weeks. It is given at 3 doses of 0.5 ml. It is given as IM dose for 4 to 6 weeks in an interval. Booster doses are given at 18 months and 5 years. Okay, 18 months and 5 years. The passive immunization is mainly antidiphtheric serum, which is administered subcutaneously. Combined can also be used, whereas the treatment is penicillin, erythromycin being the drug of choice for carriers. For carriers, you are going to use the erythromycin. Then antitoxin can also be given. It is given at 20k international units IM and 50,000 to 1 lakh international units is given. Okay, for the severe case, whereas for a mild case it is 20,000. There are again, it is two types. It is given, half is given IM, the other half is given as IV. Okay, coming to pneumonia, infection of the lung parenchyma is called as pneumonia. Typical and atypical are the types of the pneumonia. Typical pneumonia is a lobar pneumonia, whereas atypical is interstitial. It is going to affect the interstitium. So what are the causes of lobar pneumonia? Mainly it is bacteria. Okay, the bacterial pneumonia is called as lobar pneumonia. What are the causes? Most common cause is pneumococcus, that is Streptococcus pneumoniae. Then Haemophilus influenza, correct, Haemophilus B influenza, Haemophilus B. Coming to the atypical pneumonia, it is again bacteria, virus, fungi and parasite. Bacterial causes are chlamydia, mycoplasma and legionella, whereas virus, corona, influenza, adenovirus. Then fungi, it is Pneumocystis carni, then Aspergillus and Histoplasma are the causes. Coming to the parasite, there is one cause, that is Paragonimus westermani, that is a lung fluke. Now we are going to deal with typical pneumonia. Later I will be discussing atypical pneumonia, where mycoplasma is the most common cause. Here it is pneumococcus. In the pneumococcus, what are the virulence factors? Capsular polysaccharide. Okay, capsular polysaccharide. Then C carbohydrate antigen. Then pneumolysine. Then autolysin. These are the virulence factors. Coming to the mode of transport, most commonly it is the upper respiratory tract carriers. Then inhalation. Okay, inhalation of the contaminated droplet nuclei. Okay, inhalation of those contaminated droplet nuclei. Coming to the risk factors, child less than 2 years. 2 years. Then splenectomy individuals, then sickle cell anemia, comorbid diseases such as CKD, all the chronic diseases such as chronic kidney disease, chronic liver disease, chronic obstructive pulmonary disease, and chronic again it is CAD, coronary artery disease. Again it will take more time. Then diabetes mellitus and HIV patients because they are immunosuppressive on steroids. Lab diagnosis. The lab diagnosis is basically going to see the gram-positive cocci arranged in pairs, and they are capsulated. Culture, you are going to see the carom coin-like appearances. Carom coin colonies are going to see with uniform turbidity. Quelling's reaction is used to test the capsule. Going to do the Quelling's reaction. Then biochemical test is, it is very specific, it is soluble in bile, it is inulin fermenter, and it is optocin sensitive. Diseases caused are lobar pneumonia, pyogenic meningitis, otitis media, sinusitis, osteomyelitis, and septic arthritis. What are the clinical features? Fever with chills, tachycardia, tachypnea, breathlessness, pleuritic chest pain, nausea, vomiting, diarrhea, fatigue, headache, malaise, myalgia, and arthritis. Coming to the treatment, you are going to give penicillin G. Penicillin G is the drug of choice. Alternative is ceftriaxone. Oral amoxicillin can be given in case of acute otitis media. Prevention is, there are two vaccines, PPV23 and PCV7. So PPV23 will contain 23 serotypes, whereas PCV7 will contain only 7 serotypes. It is indicated in case of asplenia, sickle cell anemia, diabetes mellitus, and HIV patients, whereas it is contraindicated here in case of pregnancy and less than 3 years, whereas PCV7 it is indicated here. These two are the indications here, that is pregnancy and child less than 3 years can be given PCV7 vaccine. Coming to the satellitism, it is a phenomenon which is produced by Haemophilus influenza. It is done on the blood agar with factor 5. Okay, factor 5 and 10 are very much essential. If they are not there, this test is not going to be positive. So basically what you are going to do is, here you are going to streak the Staph aureus in a one manner, that is a vertical manner. You are going to streak it, and here for perpendicularly you are going to be streaking the H influenza colonies, because the Staph aureus is very sensitive for the hemolysis. It is going to hemolyze, and the factor 5 will be released from the Staph aureus. So this particular H influenza, it is going to use the factor 5 which is produced by the Staph aureus for its growth, and it will form the colonies. See the colonies, as it is near to the Staph aureus, the colonies are big. Once it is going far from it, the colonies are becoming small. Okay, this is what you must know. So you are going to write parallelistic Staph aureus, then release the factor 5. So H influenza colonies grow larger near the Staph aureus and decrease as they go far from this phenomenon. Will look like a satellite, as if there is some satellite. Okay, this is the main body of the satellite, and as you go far, you are going to see it is becoming thin. Okay, it is becoming thin like this. Okay, this is what is satellite phenomena. Okay, coming to the atypical pneumonia. In the atypical pneumonia, what you are going to appreciate is basically the interstitium is affected here. The interstitial space is affected. Coming to the most common cause, it is mycoplasma. Mycoplasma is the most common cause. It is a free living organism. There is no cell wall, and it is pleomorphic, and it has L forms. Okay, pathogenesis, basically this M. pneumoniae, that is mycoplasma, is going to attach to the mucosa via site adhesin. Okay, in the name itself there is adhesin. It is going to adhere, it is going to attach. Okay, site adhesin P1. Okay, this is the protein used by this particular organism. Then it will cause tissue injury. Which tissue injury? Respiratory. Clinical features are upper respiratory tract causing the pharyngitis, croup, otitis media. Lower is pneumonia. Extrapulmonary will be meningitis, rash, carditis, arthritis, anemia, all those things. Okay. Lab diagnosis is basically the specimens. In the specimens, you introduce it from the throat, and nasopharynx biopsy can also be used. Culture basically it is very specific for PPLO agar. Okay, PPLO agar is very specific. You're going to see the fried egg colonies. You're going to see the fried egg colonies. Fried egg colonies. It is very specific. Then antigen detection using the direct immunofluorescence and ELISA techniques. Then antibody detection using the indirect immunofluorescence, latex agglutination test, and ELISA. Irrespective, you can mention antigen antibody detection in all the organisms. That is what. Please go and watch my layout for lab diagnosis. There I have written all the main headings for the diagnosis for parasite diagnosis, bacterial diagnosis, fungi diagnosis, and viral diagnosis. And you are going to see antigen antibody detection in all the organisms. It can be done, and the molecular tests such as PCR, RT-PCR, real-time PCR is done again for all the organisms including bacteria, fungi, parasite, okay, and viruses. Coming to the treatment of this particular atypical pneumonia, you are going to give the macrolides, basically azithromycin. Azithromycin is the drug of choice. Alternative are doxycycline and levofloxacin. Next, coming to tuberculosis. What is tuberculosis? It is a lung disease. It is most commonly extensive lung disease caused by a acid-fast bacteria due to its mycolic acid content, and the causative agent is Mycobacterium tuberculosis. Mycobacterium tuberculosis. You are going to write it, and that particular bacteria is non-motile. First thing you must mention this. You should never forget that it is acid-fast. It is acid-fast. It looks pink. Basically, what is called as acid fastness? The ability of the bacteria to retain the primary stain irrespective of the secondary stain applied, okay, or the mordant applied, or the last stain applied, okay, decolorizer. Even after applying the decolorizer, you're going to take up the secondary stain, okay, because of the thin layer and the mycolic acid. Pathogenesis, basically it is inhalation of the aerosols, okay, aerosols and droplet nuclei, aerosols and droplet nuclei. Others such as inoculation and injection. Risk factors are sputum positive patients, increased bacillary load, overcrowding, HIV patients, poverty, comorbidity. All these are the risk factors. What is the pathogenesis? Basically here the droplet nuclei with the bacilli is going to be trapped in the upper respiratory tract. After getting trapped, it is going to adhere to the macrophage near it. So once this macrophage is there, it will not sit quietly. It is going to do phagocytosis of that particular bacilli. But after entering into the macrophage, this particular bacilli TB, it impairs the phagolysosome fusion, which I have told in the acute inflammation. To destroy a particular pathogen or the bacilli or any of the outer foreign body, it is going to form phagolysosome, which will release further enzymes and kill the bacteria. But this particular step is inhibited, okay. How? It is going to emit the calcium. It is going to inhibit the calcium, leading to the inactivation of IP3DAG pathway, which is a secondary messenger, and thereby leading to the survival, okay. It will survive inside the macrophages. It will survive inside the macrophages and start replicating, and after replicating one other day, this macrophage will rupture, and the TB bacilli which are inside is going to spread to the other macrophages and blood also via monocytes. Then clinical manifestation, mainly it is pulmonary TB. Primary and secondary are the types. Primary, you are going to see bones fungus, okay, lymphadenopathy, fever, productive cough, weight loss, night sweats, all these are seen. In secondary, you are going to see all these features are increased with necrosis. You are going to see necrosis. Extrapulmonary TB, there are variety, but the most common is TB. Lymphadenitis is the most common. Then you are going to see renal TB, genital TB, skeletal TB, miliary TB, okay. Pot spine, it is called as pot spine. You are going to study it in orthopedics, okay. You are going to study it in orthopedics. So coming to the lab diagnosis of this particular TB, you are going to collect the specimen. Specimen will be sputum. You are going to collect two specimens. One is at the spot, the other one is in the early morning. In case of children, you are going to do the gastric lavage because they don't do the proper cuffing, and you are going to get the negative sputum. digestion, decontamination and concentration techniques. Okay, this is basically done by modified Petros method and N-acetyl L-cysteine plus 2% of NaOH. What does it do? This modified Petros method, it is used in case of solid media such as LGS media, Lewin-Johnson media, which is a specific media for the culture. You're going to see Tuffy Buffy colonies. Okay, you're going to see the Tuffy Buffy colonies for TB. Then N-acetyl L-cysteine with 2% of NaOH, that is going to be used in case of liquid media. What does it do? It is going to liquefy the sputum. This NALC is going to liquefy the sputum, whereas 2% NaOH is going to kill the normal flora. So decontamination and concentration techniques are used. Next, direct microscopy, you're going to do the Zn staining. There you're going to see the long, slender, beaded, acid-fast bacilli is going to be seen. Quinones, it is a cold type of Zn staining. It is used for other bacteria such as Cryptosporidium, Cyclosporidium and Cycloisospora. All these are the parasites which are not demonstrated in normal Zn stain, whereas it is demonstrated in case of cold. Culture. Solid culture, liquid culture. Solid culture is most commonly used, that is LJ media. There you are going to see tough, rough, buff colonies. Repeat, tough, buff, rough, tough, buff, rough, tough, buff, rough colonies. Molecular methods such as PCR, CBNAT for detection of bacilli, then line probe assay. Montax and tuberculin tests are used, which I will explain later. Then IGRA, which is the upcoming and most common blood test for. It is a blood test, not a sputum test. It is a blood test. Interferon gamma release assay. Then you are going to see the treatment regarding it. What is the treatment? There are two regimens. One is for drug sensitive, the other one is for drug resistant. Drug sensitive TB is 2 months of HRZD and 4 months of HRE. First is intensive phase, the second one is continuous phase. Same way here in drug resistant TB, you are going to add levofloxacin, amoxicillin with first line agents such as pyrazinamide and ethambutol, and second line agents, the newer drugs are used are bedaquiline and delaminide. Then the other drugs which are used for resistant people are meropenem and imipenem. Vaccines. What is the vaccine used for prophylaxis or the prevention? BCG 0.1 ml intradermal, 80% efficacy, which is going to be given early. Within 1 year you are going to give the BCG vaccine. Then tuberculin test. Tuberculin test. So here the antigen used is purified protein derivative. Then the dose is not required for you, leave it. So procedure is very important. Here what you are going to do is 0.1 ml of purified protein derivative is injected to the intradermal surface. It is just given intradermal and the flexor aspect, not the extensor aspect. This is the flexor aspect. So in the flexor aspect you are going to give this purified protein derivative. So after giving, you are going to see for 48 to 72 hours. What you are going to see? You are going to see the induration. If there is any induration or something, and surrounded by erythema. This is suppose induration. This is induration, which is be surrounded by erythema, reddish erythema. Then how are you going to tell whether the test is positive? It is positive in case of more than 10 mm, then 6 to 9 mm induration with erythema. It is said doubtful, then less than 5 is negative. Interpretation of this particular tuberculin test. In case of adult, it is used as epidemiological marker because it is indicating present or past infection, whereas in child it is diagnostic. If it is positive, the child is having TB. Then false negative is seen in case of BCG vaccination and non-tuberculous mycobacterium infection. Then false negative again in early or advanced TB, miliary TB, HIV patients where there is a decreased cell-mediated immunity. Next disease is pertussis. It is a violent paroxysmal productive cough. It is a violent paroxysmal productive cough. In case of children. Virulent factors are cytotoxin, pertussis toxin and adhesins. This pertussis toxin is again similar to the cholera toxin that will stimulate the adenylate cyclase and increase the cyclic AMP. Pathogenesis, basically this particular bacteria is going to attach the ciliated cells, and there it is starting to do multiplication and produce the toxin. After producing toxin, it causes mucosal damage in the locality and impairs the immunity. Coming to the clinical manifestation, three phases are catarrhal phase, paroxysmal phase and convalescent phase. In case of catarrhal phase, you are going to see the symptoms maximally such as cold, lacrimation, mild cough, fever, malaise and coryza. In this particular things, the patient will be bit infective, not more infective. Whereas in case of paroxysmal phase, whooping cough and post-tussive vomiting will be starting. Okay, catarrhal phase, in the catarrhal phase, the patient will be maximally infective, so it can spread infection to others. Whereas in paroxysmal, it is in between. Suppose it is occurring here, then the next paroxysmal will be somewhere here, so this here is not going to transmit, whereas catarrhal continuously will be transmitting. Convalescent phase is frequency and severity is going to decrease because it is moving towards the recovery. Then complications of this particular Pertussis is subconjunctival hemorrhage and petechiae due to pressure effects and hernia and rib fracture. He will cough so hardly that he will be having petechiae, subconjunctival hemorrhage, rib fracture, sometimes hernias also. Okay. Then pneumonia as a part of secondary infection, convulsions and encephalopathy and coma being the neurological deficits. Next, our favorite recent pandemic, that is COVID. Okay, COVID, that is SARS-CoV. It is a nucleocapsid, positive strength, single-stranded RNA enveloped. It is enveloped and it is having helical symmetry with spike protein, membrane glycoprotein and envelope protein. So repeat, spike protein, membrane glycoprotein and envelope proteins are the enveloped containing components. So basically here, what is the pathogenesis? The respiratory droplets or the contact routes will enter the target host cells. So here the most common mode of transmission is inhalation, that is the droplet. Then after it binds to the S. There is an interaction between the S protein and the host cell receptor. S protein will bind to the host cell receptor, that is ACE2, angiotensin converting enzyme 2 is the receptor for this particular COVID virus. That is why these are present in lungs, so lungs are most commonly involved. Okay. Cleavage of this particular S protein is going to happen and the release of the virus will happen into the host cell. Once this is released, there is a fusion of S protein breaking of this S protein, that is leading to S1 subunit and S2 subunit. What does this S1 subunit do? It will bind to ACE2 receptor, then S2 will help in fusion of the virus. Then next is influenza-like illness. It is going to cause influenza-like illness and inflammation. This is the thing which is caused here. You are going to highlight it properly. Influenza-like illness with inflammation. So once there is inflammation, there is release of cytokines. After release of cytokines, the cytokine storm will occur, then that will lead to pulmonary edema and acute respiratory distress syndrome. Coming to the clinical features such as fever, fatigue, myalgia, productive cough, breathlessness, rhinorrhea, diarrhea, anosmia, loss of taste, all these will occur. So clinical grading or the severity: mild disease, moderate disease and severe disease. In severe disease, there are again subtypes: severe pneumonia, ERDS, sepsis and septic shock. Coming to the mild disease, you are going to have mild fever, cough, sore throat, malaise and headache. Whereas moderate, you are going to see dyspnea, fever, cough and SpO2 is less than 94 and respiratory rate is less than 24. You are going to remember these values, these are important. Whereas in case of severe pneumonia, you are going to see the pneumonia like clinical features such as fever, increased respiratory rate, chest retractions, all these are seen, confusion. Okay, curve 65, you remember that, right? That is a grading used for pneumonia. Then one of these following should be positive, so that is respiratory rate more than 30, then SpO2 less than 90. These are the things you are going to remember. Then coming to the ARDS, that is acute respiratory distress syndrome, you are going to see the bilateral chest infiltrates with lung collapse, and you are going to see decreased FiO2 and PoO2, and the normal FiO2 or PoO2 is 500. If it is less than 300, it is mild, less than 200, it is moderate, less than 100, it is severe. Sepsis, you are going to grade it with Q-SOFA score, which is accompanied by the multi-organ dysfunction syndrome, that is MODS. Then lastly, septic shock. There you are going to maintain the BP more than 65 mmHg, and serum lactate will be more than 18 mg per deciliter. Going to monitor this. Then lab diagnosis. In the lab diagnosis, you are going to collect the specimen. In case of specimen collection, nasal and throat swabs are collected with the proper personal equipment. Okay, personal protective equipment. Then real-time RT-PCR is done. Automated real-time RT-PCR is done to quantify the viral load. Then antigen detection, antibody detection, sequencing of the virus. Then virus culture. Okay, virus culture has also been done. Non-specific. Okay, these were done during our COVID hospital duties. That is D-dimers, serum ferritin, C-reactive proteins. All these are done as a part of follow-up for the patient. Non-specific, but still they were done. Then CT, bilateral ground glass opacities. GGO means ground glass opacities. They are subpleural in nature. They are very subpleural. Treatment, you are going to give the symptomatic therapy such as oxygen supplementation, NIV, that is non-invasive ventilation. MV means mechanical ventilation for people who are having dropping of the saturation and not stable. Then intravenous fluid for the patient who is in septic shock. Then remdesivir, that is inhibiting RNA independent RNA polymerase, that is 200 mg IV on the day 1 followed by 100 mg IV for 5 days. Plasma therapy can also be used. Then the new was tocilizumab, which is a interleukin 6 inhibitor. Then hydroxychloroquine and steroids were given for the better outcome of the disease. So coming to the prophylaxis of the disease. In the prophylaxis, chemoprophylaxis, hydroxychloroquine, then COVID vaccine, that is Covaxin and Covishield. Covaxin and Covishield was given. Prevention, basically, these are all non-specific. In the hospital side, we used to do, remember, hand hygiene, you're going to wash your hands. Then use personal protective kit. Then environmental cleaning, the D groups used to clean neatly. Then cough etiquette, you used to scold the patient properly. Don't spit here and there, don't sneeze here and there, like that. Okay. Then public, what they used to do social distancing, so 1 arm distance. Okay, please be far. They used to mark circles. In circles only you're going to stand there. Then wearing masks, you're going to wear masks. Then what the government took the initiative as doing quarantine for the far coming people from abroad or any other places. Then lockdown was done. Okay, lockdown was done. Antigenic shift and drift, this is the 3-mark question, which is done by a phenomena of influenza. So antigenic shift is basically a point mutation, whereas antigenic drift is because of genetic reassortment. Then where you are going to say it in hemagglutinin and neuraminidase gene. So here it partially escapes the host immune response. Here it escapes host immune response for longer duration. Then it is produced by A and B. Here it is produced only by A. Here it is only produced by A. Then it causes outbreaks and periodic epidemics. It causes pandemics and major epidemics. It occurs for 2 to 3 years. It occurs for 10 to 20 years. Compare it and read. You are going to finish it quickly. Then Powell-Bennell's test. It's a heterophile agglutination test where I mentioned the comparing. They are having the same haptens. Go and refer the immunology chapter. Heterophile agglutination. There I have told heterophile antigens. So Powell-Bennell's is an example. It's a type of tube agglutination test. Here the principle is agglutination. Okay, with the sheep RBCs to detect the heterophile antibodies in the patient serum to detect the HBV. So basically serum is mixed with 1% sheep RBCs and incubated at 37 degrees Celsius for 4 hours. Okay, then after this you are going to see the titer. It should be more than 256 to say it as positive. So false positive is seen in case of normal, so it is not so sensitive. So confirm it by monospot test and differential absorption test. Next, going on to the fungal diseases, that is mucormycosis. In the mucormycosis, it's a group of life-threatening infection caused by aseptic fungi called mucor. Inhalation and inoculation are the types of transmission. Here the spores are inhaled and develop into a mycelial form, that is aseptate hyphae. This is being angioinvasive, it spreads the infection. The risk factors are diabetic ketoacidosis and end-stage renal disorder patient, the patients on iron therapy, neutropenia patients, and steroid treatment because they are taking steroids and their immune is suppressed. Okay, their immunity is suppressed. Clinical features, most commonly it is rhinocerebral mucormycosis. You are going to write this word. If they give mucormycosis, never forget to write this particular rhinocerebral mucormycosis. Seeing this, the examiner will be giving marks because it is very, very specific for mucor. And this particular thing will be having eye and facial pain, orbital cellulitis, proptosis, and loss of vision. Pulmonary mucormycosis is the second one. You can write pulmonary also second after writing rhinocerebral, remember it. So since it is involving pulmonary, it is going to cause dyspnea, cough, chest pain, fever, and chest x-ray will reveal consolidation and cavities. And the cutaneous is the last type, GI disseminated in case of brain. Lab diagnosis, you are going to do HPV and HE, that is H&E and histopath. Aseptate hyaline hyphae with wide branching. Okay, wide branching. So you are going to see the wide branching. Culture will be on the SDA, Sabaron Streptococcus at 25 degrees Celsius. You are going to see white cotton woolly. Okay, white cotton woolly colonies with salt and pepper appearance. On the LPCB, that is lactophenol cotton blue, you are going to see the broad aseptate hyphae with sporangiospores. You are going to see the sporangiospores. There are no rhizoids here. Remember, there are no rhizoids. Rhizoids. Treatment is amphotericin B is the drug of choice. Posaconazole can also be given as an alternative. Coming to Aspergillosis, which is the next. It is an invasive allergic disease caused by Aspergillus species such as Aspergillus fumigatus, Aspergillus flavus, and niger. Mode of transmission is inhalation of the conidiospores. You are going to inhale the conidiospores. Risk factors is steroid therapy, profound neutropenia, neutrophil dysfunction, pneumonia, COPD, TB, anti-TNF treatment. All these, okay, will be the risk factors. Coming to the Aspergillosis, it is pulmonary here. Here it is pulmonary. You must mention pulmonary here. There you mentioned rhinocerebral. Here you are going to mention pulmonary. In the pulmonary, it is going to cause allergic pulmonary. Okay, allergic bronchopulmonary aspergillosis. ABPA means allergic bronchopulmonary aspergillosis. Then severe bronchial asthma, aspergilloma, fungal balls, invasive sinusitis, cardiac aspergillosis, cerebral aspergillosis, ocular, then otitis externa, cutaneous, onychomycosis. Okay, all these are seen. Then coming to the lab diagnosis, you are going to see specimen, sputum. Okay, sputum is collected in tissue biopsy. Direct examination from the KOH mode or HPE, septate hyaline hyphae with acute. Okay, here the acute angle branching is going to be seen. Then the species differ here. Smoky green indicates fumigatus, whereas yellow green. Okay, yellow green indicates flavus. Black cotton indicates niger. LPCB will show conidiospores. Antigen detection, here you are going to detect what? Beta D glucan and galactomannan, which are very specific for this particular aspergillosis. Okay, then antibody detection, skin tests to detect the hypersensitivity. Treatment invasive aspergillosis, it is voriconazole, whereas for all it is amphotericin B. Rest all invasive, it is amphotericin B, liposomal. Then APPA, it is itraconazole, whereas aspergilloma you are going to do the surgery. For prophylaxis you are going to give posaconazole. So this is the diagram you are going to draw. If you cover 1/3, it is Aspergillus fumigatus. I have mentioned in general. If you are going to cover it as 2/3, it is flavus. If you cover full, it is niger. You are going to draw full spores. I have not drawn. You are going to draw full spores like this for this also, for this also. These are the conidia out. Then below that is phyllites. Below that is a vesicle. Then it is the conidiospore stem. Then it is going to stand it on a septate hyphae. So basically here it is conical in shape, here it is globular in shape, here it is vesicular in shape. Pulmonary infection caused by the fungi or parasites. Fungi will cause mucormycosis, Aspergillosis, Streptococcus are the fungi infections. Then parasite, it is Paragonimusis, okay, caused by Paragonimus westermani lung fluke. Then tropical pulmonary eosinophilia, TP. This is the 3 markers I have not mentioned. Please go and refer. Okay. Meningitis, most commonly acute pyogenic meningitis will be asked like a 10-marker question where they will give it as septic meningitis also. Okay, it can be given as septic meningitis or acute meningitis or pyogenic meningitis. All these are same. It is caused overall by Streptococcus pneumoniae. Okay, then meningococcus and H influenza. In neonates, it is Streptococcus agalactiaceae, that is group B Streptococcus. Then coming to the route of infection. Correct. It is a route of infection. ROI means route of infection. Hematogenous spread, direct spread from the infected site. Risk factors are neonates, alcoholic people, diabetes mellitus, immunocompromised patients, splenectomy individuals, breach in the blood-brain barrier, and CSF shunts which are used. All these will act like a risk factor for developing of meningitis. Then at last it is clinical manifestation. There you are going to see fever, projectile vomiting, neck rigidity. Okay, these are very specific. These three are very specific: fever, projectile vomiting, neck rigidity. Then the signs are Kernick sign, Brudzinski sign. Irritability to feeding is seen specifically in the babies. Okay, you're going to see what is Kernick sign and comment below, and what is Brudzinski sign to help your friends. So basically, how we are going to tell it is Kernick's positive, it is Brudzinski form. Please comment in the below. Okay, please comment below. Complication. Okay, complication. What are the basically the complications? Meningoencephalitis is the complication. So you're going to see decreased consciousness, seizures, increased intracranial pressure, and stroke. These are the things you're going to see. Then lab diagnosis. What are the lab diagnoses you're going to see? CSF collection via lumbar puncture. You're going to collect the CSF, you're going to transport it, incubate at 37 degrees Celsius. Then blood culture. CSF analysis basically pyogenic and tuberculosis and aseptic or viral. CSF pressure is maximally increased in case of septic, and it is normal in case of viral, and it is mildly elevated in case of TB. Whereas total leukocyte count, it is 100 to 10,000 here. Again it is 10 to 500. Here it is 25 to 500. Then cell types. Cell types in case of septic, that is acute, it is neutrophils because they are the cells of acute inflammation. Whereas TB, it is lymphocytes because TB bacilli will target the lymphocyte and being a chronic infection. Then viral also will target the lymphocytes. Glucose, it is being taken by the bacteria, so the glucose will decrease or being absent also sometimes. TB, it is not taking more, it is taking very less, so it is slightly decreasing. Whereas virus, it doesn't use glucose, so it is normal. Whereas protein, it is maximally increased in case of septic or pyogenic. In tuberculosis, mild increase, whereas in case of aseptic, it is increased or normal. CSF microscopy, you are going to see gram stain to identify the agent. Direct antigen detection such as from the latex agglutination test. Okay, direct antigen test, that is latex agglutination test, and immunochromatography from urine. Culture, chocolate agar, blood agar, and differential media, and antibiotic susceptibility testing is done. Caram coin, Streptococcus pneumoniae. Intracellular gram-negative diplococci, Neisseria meningitidis. Satellitism, H influenza. Okay, beta hemolysis, Streptococcus agalactiaceae. Okay, CAMP test is positive. These are very specific, that's why you are going to remember at least this much. Then E. coli, lactose fermenting colonies, those are pink in color. Serology is also fine. Then molecular techniques such as multiplex PCR, real-time PCR. Treatment is IV ceftriaxone. For adults. For neonates, it is IV ampicillin plus gentamicin. You can also give IV dexamethasone to decrease the intracranial pressure. Next, coming to the poliomyelitis. I have entered CNS, I didn't tell it in between. So from the meningitis, the CNS has started. So now it is poliomeningitis. It is highly infectious childhood disease causing the acute flaccid paralysis. AFP means acute flaccid paralysis caused by the agent poliovirus belong to picoRNA. It is icosahedral shaped and antigen types are wild polio viruses. Pathogenesis fecal-oral route, then followed by respiratory droplets, leading to the multiplication in the local areas of the intestinal epithelial cells, then entry into the host cells by binding to CD155 receptor, CD155 receptor, then spread to CNS or spinal cord. They spread to the CNS or spinal cord via hematogenous route or neural route, act to the motor nerve endings at the last, leading to the muscle weakness and acute flaccid paralysis. Clinical features: fever, malaise, sore throat, myalgia, headache. I need not explain, it is common in case of any of the itis. Paralytic polio, that is less than 1% you are going to see it, and it is asymmetric and acute flaccid paralysis. Then non-paralytic poliomyelitis, it is similar to the presentation of meningitis, then asymptomatic in many of the cases. So here itself they are going to ask the 3-mark question of poliomyelitis clinical features. You are going to say the normal clinical features. They are initial, then these risk factors being old children, adults, pregnant females, okay, trauma induced patients, tonsillectomy done procedure, childs, then IM injections. Lab diagnosis is specimen from the throat, antibody detection, then real-time RT-PCR and cell line from primary monkey kidney. Vaccines used are IPV, that is salk variety, and OPV, that is Sabin variety. Here it is given IM, that is 0.5 ml IM, whereas OPV bivalent strain more commonly used is 1 and 3. These are the things you must know regarding the poliomyelitis, which can be asked for 5 marks, whereas Japanese encephalitis is the next thing you need to concentrate on. So basically, what is the vector for a particular Japanese encephalitis? It is Culex. The transmission cycle is of 2 types, that is pigs, Culex, then animal hosts such as birds, Culex, birds, okay, birds, Culex, birds. So basically these animal hosts are basically pigs, which can be used as amplifiers or host. Pigs are amplification or host. Next, epidemic in the Southeast Asia. You are going to see Southeast Asia epidemic. Clinical manifestations are incubation period. I have never mentioned in any of the diseases. It is horrible to remember all those infectious period. If possible, you are going to remember. Here it is 5 to 15 days. Most commonly it is subclinical. If it is clinical, it has 3 stages: prodromal, acute encephalitis stage, and late stage. In the prodromal, it is having just febrile illness. In the acute encephalitis, you are going to see fever, confusion, delirium, seizures, disorientation, and coma are seen, whereas in late stage you are going to see the neurological deficits. Lab diagnosis is basically on the IgM ELISA antibody detection, then molecular methods such as RT-PCR and real-time RT-PCR. RT-PCR is done for RNA virus, whereas PCR is done for DNA virus. Treatment, you are going to do the supportive treatment, then there is no specific antivirals, okay. Vaccines, there are 2 vaccines, live and killed. Live strain is called as SA1414-2 and killed variety is called as Nakayama Beijing strain, whereas SA1414-2 you are going to give 2 doses, whereas Nakayama also you are going to give 2 doses. Here it is given in national immunization schedule at 9th month to 12th month and 16 to 24 months, okay. 0.5 ml subcutaneous upper left arm, whereas 2 doses 4 weeks apart. 0.5 ml IM is given here. Here it is subcutaneous, here it is IM. Then catch up, it can be given up to 15 years in the areas of outbreaks. Coming to rabies, in the rabies you are going to see it is rapidly progressive acute infectious disorders of CNS in humans, and the causative agent is rabies virus, and the causative agent is rabies virus, which is bullet shaped. You are going to draw it like a bullet and you are going to mention all these things. The outer glycoprotein, these all standing out structures are glycoproteins. Next to that is bilayered lipid, then inside it is matrix proteins. Then this thing is a negative sense RNA attached to a RNA polymerase, which is enveloped. Remember, it is enveloped virus. Transmission. The transmission is basically from the bite from the infected animal, direct contact with the saliva or the inhalation. There is no human to human transmission. Spread of the virus is basically local multiplication at the inoculation site. Then virus will enter into the peripheral neurons, then entering into the neuronal spread leading to dorsal root ganglia spread. After that, this entire CNS infection will be set in, and from the CNS infection, this infection will start spreading away from the CNS, and that is called as centrifugal. Centrifugal. Fugal means far, going far from the center. That is centrifugal. Centrifugal. Centripetal means coming near. It is going to the center, whereas centrifugal is going far. Clinical manifestations is, again, incubation periods is very long, 20 to 90 days. 20 days to 90 days. Prodromal phase, you are going to see fever, malaise, nausea, vomiting, sore throat, photophobia. All these are seen. In case of acute, it is again acute neurological phase. It has encephalitis, rabies, which is going to cause the encephalitis, whereas dumb rabies, it is not so late, it is causing late infection. In case of acute, the patient is anxious, agitated, bizarre behavior, increased lacrimation and salivation, hydrophobia and aerophobia are seen. He can't drink water also. Give him a glass of water, he will throw it. And even he feels very difficulty to take breath also. Okay. And the patient will be very restless, agitated, anxious. Okay. In case of dumb rabies, the people will have partially vaccinated or partially infected. Such patients will be having dumb rabies. Here you are going to see the flaccid paralysis, which will be later be converting into quadriplegia, including the facial palsy. Coming to the lab diagnosis of this particular rabies, that is rabies antigen detection using the direct immunofluorescence, which is a gold standard. Then virus isolation, mouse and cell lines, that is baby hamster kidney is used. Okay, cell lines used are baby hamster kidney. Antibody detection in case of CSF, and viral RNA detection, negative body detection, which are intracytoplasmic eosinophilic inclusions with basophilic inner granules with viral RNA. Then immunohistochemistry can be used for this particular negative bodies. Remember, this is having 100% mortality, so treatment is isolation, sedation and hydration of the patient. Just palliative therapy. You should just watch the patient die. Post-exposure prophylaxis. Post-exposure prophylaxis depends on the bite of dog. Category 1, Category 2, Category 3. Category 1, you are going to use just wound care. Whereas in Category 2, you are going to give the wound care, you are going to give the vaccine. Whereas in Category 3, wound care, vaccine and immunoglobulins are also given. Passive immunization is also given. With active immunization, you are going to use passive immunization of immunoglobulins. Wound care is basically physical cleaning of the wound with fresh running tap water, then chemical inactivation of the viruses by using alcohol related things, but never suture the wound. Pre-exposure prophylaxis, you are going to give 2 site and 1 site. 2 site in case of intradermal. Remember, 1 site because intramuscular is going deep, so 1 dose is sufficient. Whereas intradermal, it is very superficial, so you require 2 sites. Okay. On day 0 and day 7, booster dose is not required because it is not helpful. Then prevention, elimination of all the stray dogs and mass immunization of the dogs. Causes of viral encephalitis, they are going to ask. It is HSV1 more than 2, cytomegalovirus in case of HIV patients, then the Japanese B encephalitis virus, rabies virus, Nipah virus, Epstein-Barr virus, West Nile virus and measles are the causes of viral encephalitis. Coming to the prions disease, what are prions? These are infectious proteins. Particles lacking the nucleic acid. They are resistant to physical and chemical agents of sterilization. And what happens is basically there is a conversion of normal PRPC protein into PRPSC. Okay, PRPSC. So this is going to accumulate. So clinical features are loss of muscle control, shivering, myoclonial jerks, loss of coordination, rapidly progressive dementia. All these are the clinical features. Whereas the disease caused in case of humans is Kuru and Creutzfeldt-Jakob's disease, CJD. There are 3 types: sporadic, familial and variant CGD. Lab diagnosis is basically, again, there is a measurement of PRPSC levels, electron microscopy, gene sequencing of PRNP gene and abnormal EEG. There is no specific effective treatment seen of this particular disease. Toxoplasmosis. What is toxoplasmosis? It is a causative agent is Toxoplasma gondii. It's a parasite. Toxoplasma gondii. Morphology is again asexual form and sexual form. It's a parasite. Remember, it is a parasite. Definitive host is cats and intermediate host is man. Asexual cycle is there is ingestion, tachyzoids are formed inside the blood and tissue sheets leading to bradyzoids. That is asexual cycle. Whereas sexual cycle, you are going to see the bradyzoids in the tissues, then those bradyzoids are going to be converted into schizogony, then gametogony, leading to formation of zygote, oocyst, and secreting the cysts in the fecus of the cat. Risk factors are the people who are having HIV, people undergoing blood transfusion and organ transplantation, and HLA-DQ3. In case of France, the people eat cat, so infected cat eating can also lead to risk factor of getting this disease, toxoplasmosis. Immunocompetent patients will have just lymphadenopathy, headache, malaise and fatigue and fever, whereas immunocompromised will have directly encephalitis. Congenital toxoplasmosis is very important, which is the most common encountered congenital torch infection. Okay, TORCH. You are going to read what you are going to comment in the section. What is the triad of this toxoplasma in the congenital phase? Chorioretinitis, hydrocephalus and intracranial calcification. Lab diagnosis is direct microscopy, antibody detection using IgM and IgG, Sabin-Feldman dye test. Sabin-Feldman dye test. So gold standard. Antigen detection and PCR. Treatment is cotrimoxazole for HIV patients. For more than 14 days is the drug of choice for primary prophylaxis. Dapsone and pyrimethamine can be given as alternatives. Neurocysticercosis. Neurocysticercosis. It is a cranial complication of cysticercosis caused by whom? You are going to comment again in the section. It is tinea. Which species you are going to comment down. Then types. Types is basically parenchymal and extraparenchymal. Mostly asymptomatic, but seizures are seen in case of 70% individuals. So seizures are seen. Then hydrocephalus in case of extraparenchymal. Others are increase in the ICP, that is headache, vomiting, vertigo, deficits and dementia. Morphology is vesicular, necrotic and calcified. This is how the neurocysticercosis is going to progress. First it is vesical, then necrotic, then calcified. Most commonly associated with HIV patients. Treatment is steroids, first basically steroids, then you are going to give albendazole. Significant bacteria, I'll explain in UTI. You just remember more than 10 to the power 5 colony forming units per ml is positive. Okay, that is called as significant bacteriuria. We are going to refer this in UTI. Then coming to the schistosomiasis. Schistosomiasis is basically the causative agent is Schistosoma hematobium. Schistosoma hematobium. Hosts are definitive host and intermediate host. Okay, these are the things you need to remember. Mode of transmission is skin penetration. Clinical features is urogenital disease, obstructive uropathy and bladder cancer. So diagnosis again X with the terminal spine. Remember, if they give history X with the terminal spine, it is Schistosoma hematobium leading to schistosomiasis. Antigen detection and antibody detection using the ELISA. Treatment is praziquantel. Next, coming to the UTI. So in the UTI, you are going to concentrate basically these things. That is, it is a disease caused by microbial invasion of urinary tract that extends from the renal cortex to the urethral meatus. Lower UTI is basically urethra, bladder, and it is a type of ascending spread with dysuria, urgency and frequency. Whereas upper UTI, it is kidney, ureter and descending spread leading to fever and abdominal pain. Risk factors bring females, old age, pregnancy, benign prostatic hyperplasia, ureteric stones. All these are the risk factors with reflex nephropathy in case of congenital babies. Causes, most common causes E. coli, that is both community acquired and hospital acquired. 70% cases is by E. coli. What are the other causes? Klebsiella, Proteus, Pseudomonas, Staph aureus, Candida, Schistosoma hematobium, all these. Pathogenesis, pyelonephritis is the main here. Here remember colonization. So these are the two things you need to remember. First is pyelonephritis, the other is colonization. Colonization is going upwards towards the bladder, that is cystitis. Then going upward again, that is causing pyelonephritis. But pyelonephritis coming back and causing AKA and coming downwards towards cystitis and colonizing areas, then it is descending. So AKI means acute kidney injury. Clinical manifestations of this particular disease. Clinical manifestation. Lower UTI will be having asymptomatic bacteria with cystitis and urethritis, whereas upper UTI, pyelonephritis, urethritis and renal abscesses. Treatment and the immunological sequelae will be PHGM. Lab diagnosis is again clean void midstream urine is collected, suprapubic aspiration is done in coma and infants, and catheterized patients you are going to take it from tube, not from the back, transported using the processed immediately. Okay, processed immediately. Direct examination will reveal wet mount, leukocyte esterase test and nitrate rejection test, and gram stain. It is not reliable for urine specimens. Then culture, very specifically clade agar more than McConkey agar. Now I am going to tell significant bacteriuria. So if the count is more than 10 to the power 5 colony forming units, it indicates it is having significant infection, that is significant bacteriuria. Then the count is between 10 to the power 4 to the 10 to the power 5 colony forming units per ml. It is doubtful. If it is less than 10 to the power 4, it is negative. It is absent. Lactose forming colonies are seen in case. Okay, so pink and yellow lactose forming on McConkey. If you go into see this, they are lactose fermenting, and the examples are E. coli and Klebsiella, whereas others non-lactose pale colonies will be seen in case of Pseudomonas and Proteus, and antibody detection is also done. Treatment is basically perform the AST first, that is antibiotic sensitive susceptibility testing. Then you are going to give norfloxacin, which is being the drug of choice. Then nitrofurantoin, high generation, that is 4th or 3rd generation cephalosporins aminoglycosides are given. In case of hospital acquired UTI, you are going to give the carbapenems because they are more resistant for normal. Then beta lactams with beta lactam inhibitors, that is you are going to give the Pibzo, that is piperacillin with tazobactam. It is called as Pibzo. This is what regarding the disease of UTI. Then coming to the sexually transmitted diseases, so we are going to start it with syphilis. Genital, we have started with UTI, remember. Now we are going to teach the genitals only again, with syphilis being the first. Treponema pallidum is the causative agent. Pathogenesis is sexual mode of transmission is the most common. Direct contact can also occur, and blood transfusion also can be leading to this. Spread is basically penetration through the minute aberrations entering into the lymphatics. Through the minute aberrations, it is going to enter into the lymphatics. Once it enters the lymphatics, the primary infection is set in. Clinical manifestations being the primary syphilis, primary chancre or hard chancre, painless ulcer over penis. Then regional lymphadenopathy, that is painless, firm, non-suppurative and often bilateral. Secondary syphilis will be have skin rashes, condylom malata, that is genital warts, then mucosal patches. Latent will have no clinical features, but you are going to see it. If you are going to see some, it is early and late within first year, and after 1 year it is late. The tertiary syphilis will have specifically gummas. They are destructive granulomatous diseases. Then neurosyphilis and cardiosyphilis. Neurosyphilis will lead to chronic meningitis and vasculitis, whereas cardiosyphilis is leading to aneurysm of ascending aorta and aortic regurgitation. Congenital syphilis is also seen. You are going to tell the triad of congenital syphilis in the comment below. So lab diagnosis is dark ground microscopy, direct immunofluorescence for staining, then silver impregnation, rabbit test is for the culture, serology such as non-treponemal tests which are very specific such as VDRL and RPR, then treponemal tests such as TPI, FTAABS, TPA, TPHA. You remember this T, and those T's are for syphilis, remember that way. And PCR as usual. Multiplex is the PCR type you are going to use here. Then test for HIV because syphilis patient will have HIV. Then penicillin is the drug of choice here. Penicillin is the drug of choice. Alternative is for primary, secondary, or latent or CVS, you're going to give tetracycline. Prevention is treatment of the cases and contacts, education about the safe sex practices using condoms, then prophylactic use of the barrier contraceptive methods. Then lymphogranuloma venereum is the next disease I'm going to start. That is invasive sexually transmitted diseases, infection caused by chlamydia trachomatis is the causative agent. Chlamydia trachomatis, that is L1, L2, L3 serotypes. First stage you're going to see painless ulcer, just painless ulcer over penis or vulva. Then second stage you're going to see inguinal lymph nodopathy. It is becoming enlarged, tender and soft, that is called as bubo. Inguinal buboes are seen. Coming to the other things which are seen, fistula, gross sign, fever, headache, myalgia as usual. Third stage you're going to see rectal stricture, rectal fistula, rectovaginal stricture, elephantiasis. There is something new for you, that is estheomean. What is estheomean? The vulva or the penis will become edematous vulva or pena with the granuloma. It is called as estheomean. Remember, what is it? Estheomean. Diagnosis, serology. Serology, nucleic acid amplification tests such as PCR. Then antibody detection using ELISA and immunofluorescence. Then detection of inclusion bodies using direct immunofluorescence culture. Treatment is long course of doxycycline for 21 days. Azithro is the alternative used. So this is about this. Next, moving on to the gonococcal urethritis. In the gonococcal urethritis, we are going to tell the causative agent as Neisseria gonorrhea. Then it is a gram-negative kidney-shaped diplococci causing the sexually transmitted infection, which will manifest as cervicitis, urethritis and conjunctivitis. Virulence factors being pili or fimbriae with porin and opacin proteins. These are the proteins. Porin for pouring it, opening, and opacin for opacity associated protein. They are also called as protein 1 and protein 2. You are going to write it as like that also, it's fine. Clinical features: in case of female, it is purulent urethral discharge and water can perineum in case of males, whereas in case of females, you are going to say mucopurulent cervicitis and vulvovaginitis. Neonates, it is ophthalmia neonatorum. Mode of transmission is sexual and vertical from mother to baby. Lab diagnosis is 3 marker again. Here you are going to give specimen collection from urethral swab. Then transport media is Stewart's media, amines media. You are going to remember these medias. Then microscopy, you are going to see gram-negative diplococci which are kidney shaped. This is the kidney shape. Kidney shaped. Then culture. Diplococci means you are going to draw extra one here. It is diplococci. They are always together. Then culture, and they are intracellular. Remember, they are intracellular. Culture, it is in Thayer-Martin media, that is containing chocolate agar with antibiotics. Then it is catalase positive, oxidase positive. It is going to ferment just only glucose but not maltose and sucrose. And PCR is the other diagnostic methodology. Coming to the treatment, ceftriaxone or cefixime are the drugs used. Both are single dose. Ceftriaxone 250 mg, cefixime 400 mg. It is oral, this is IM. If associated with chlamydia, we are going to give the doxycycline or azithro. Prophylaxis being early detection of cases, treatment of both partners, trace the contacts, and health education about the safe sex practices. Next, bacterial vaginosis. Bacterial vaginosis, usually this is a commensal, but once if this concentration is increasing, that is Gardnerella vaginalis concentration is increasing and the lactobacilli decreasing physiologically, then gone. It is going to cause bacterial vaginosis. Risk factors being immunocompromised patients such as HIV, chlamydia associated infection and Neisseria gonorrhea associated infection. Then recent unprotected vaginal intercourse, vaginal douching, which is done in case of vaginal hysterectomy to clean the vagina to keep it sterile. Then PROM, that is premature rupture of membranes, PROM. Then PTL means preterm labor. Clinical diagnosis is basically based on the MCELS criteria. Here you are going to see at least you should have 3 out of these 4 should be positive. So basically What are the 4 points there? Slight to moderate increase in the thin white homogeneous discharge. Then pH of the vaginal discharge should be more than 4.5. Then accentuation of the distinct fishy odor on mixing with 10% KOH amount, that is called as whiff test. If you are going to mix the solution with the KOH amount, it is going to cause fishy odor and it is going to increase maximally. Then clue cells, which are the vaginal epithelial cells coated with the bacteria. Lab diagnosis being Nugent's, Nugent's score, that is again counting the bacilli on the smear using the gram stain. If it is more than 7, it is called positive. Culture is based on the chocolate agar and brain heart infusion broth, where you are going to see the gram negative cocobacilli non-motile with alpha hemolysis on the blood agar. Alpha means partial. Molecular techniques are being used and broad range PCR. Broad range PCR is used here. Metronidazole for 7 days BD, twice daily, is the treatment. Suppose these are the clue cells, you are going to see something adhering to the cell wall of this particular clue cells. Those are the coated bacilli. Coming to the next topic, that is trichomoniasis. Causative agent is Trichomonas vaginalis, flagellate and amoeboid. Flagellate and amoeboid are the two forms. It has two infections. One is acute infection, next is chronic infection. In case of acute infection, it is called as vulvovaginitis, where you are going to see thin, profuse, foul-smelling, purulent, green discharge. Remember, green discharge. And strawberry cervix, and dysuria with lower abdominal pain. Chronic infection will lead to mild pruritus with pain during the coitus. Then during discharge will be scanty here. The discharge will be scanty here. Complications being pyosalpinx, endometritis, infertility, low birth weight, HSV infection and HIV infections are going to increase, and cervical erosions are more common. Lab diagnosis being wet mount, where you are going to observe the trophozoites. You are going to stain with GIMSA or PAP. Then you are going to detect it by direct fluorescent antibody. This is the most sensitive. Then culture is going on lashed cystine hydrosylate media. Serum media, it is a serum media that is called as lashed cystine hydrosylate serum media. Antigen detection from the vaginal secretions using ELISA and immunochromatography, and antibody detection using ELISA. Molecular tests from PCR. Remember, just imagine without PCR and ELISA, the microbiology would have been so backward. Because of these two investigations, so many diagnoses are happening. Hats off to the scientists or the people who have invented it. Treatment: metronidazole and tinidazole. Metronidazole and tinidazole, you are going to give 2 gram single dose. Prevention is again treatment for the both partners. You are going to treat both partners. Then safe sex practices. Then avoid sex with the infected person. Don't come in contact with them. Zika virus's complications in pregnancies. Basically, it is going to cause fever with rash and conjunctivitis. Then congenital Zika syndrome, which is going to cause microcephaly. Then Guillain-Barré syndrome for the baby born later. Then neuropathy and myelitis are seen. So we are going to diagnose using NAT, that is RT-PCR, and IgM antibody detection for acute infection. It is very deadly. The mortality rate is very high, and there is no antiviral also for this particular Zika virus, and it spreads even by drinking water. If that person is drinking water and he has left the bottle half drinking and you are going to drink that water, then that is going to cause infection for you, and it is deadly also. Oncogenesis is done by which of the following? I have told it in patho, but still I'll repeat here. DNA oncogenic viruses, RNA oncogenic viruses. In the case of DNA oncogenic viruses, it is human papillomavirus causing cervical cancer, Epstein-Barr virus causing Burkitt's lymphoma, HHV8 causing Kaposi's sarcoma, and HBV causing hepatocellular carcinoma. These are the DNA viruses. Next, RNA oncogenic viruses are HIV causing AIDS and HCV causing hepatocellular carcinoma again. Lymphoma, basically HIV will cause lymphomas. Zoonotic diseases, these are all the bacteria, these are all the virus, these are all the fungi, and this too is parasite. Anthrax, plague, brucella and leptospira, these are all the diseases of zoonosis. Anthrax, plague, brucellosis, leptospirosis. Then rabies, Japanese bee, encephalitis, yellow fever, occasional forest disease of Archimoga, then cryptococcosis, histoplasmosis, toxoplasmosis, leishmaniasis are the zoonotic diseases. Coming to plague, the plague is causative agent is having Yersinia pestis, reservoir is rodents, vector is rat flea. Mode of transmission is basically bite of this rat flea. Okay, then inhalation of the droplet via droplet nuclei. What are the types of this particular plague? Types of plague are bubonic plague, pneumonic plague, and septicemic plague. Remember the safety pin appearance, gram negative, coccobacilli. Treatment is streptomycin for 10 days. Alternative is gentamicin, but presently gentamicin is being proven more effective than streptomycin, so they are going to use. Then levofloxacin has post-exposure prophylaxis, and doxycycline. Bioterrorism agents are category A is anthrax, botulism, plague, and smallpox. Then category B it is brucellosis, Q fever, typhus fever. Then category C it is Nipah virus and yellow fever virus. Okay, this is all about the second part of the microbiology. So this is what I felt which are the most important topics. Some of the topics are not covered, so those topics will be mentioned in the description. So you're going to just refer it from the textbook of Apurva Shastri, or whatsoever the standard textbooks such as Panikar also, it's fine. So if you are going to like the video, please you're going to share it for your friends. Okay, you're going to share. I have taken so much of efforts to do it. Writing so much thing is not a joke. Okay, it will take so much of time and with the consistent same handwriting. So you people are going to support me in the same manner and stay till long way to go. So I wish you people all the best in the exams, and you're going to do the best. Make sure you're going to share, like, and subscribe my video and share it to the other peoples. So meet you in the next video as soon as possible. And okay, then see you. Bye.